What I'm hoping to do today is cover a bit about what specialist care is, why is it important in neuroendocrine cancer, what are ENETs centres, do you need to be seen, physically seen at a centre, referral pathways, what they are and being referred, and then just a quick update on some of the work we've been doing and also the national plan consultation and where this may all fit into that. And then obviously the Q&A session at the end. So, first off, what is specialist care? So, as many of you may be aware, the whenever you go into hospital, there's multiple different departments, and that's because healthcare is usually split up into either a defined group of patients, their disease, and or other factors. So we see it where you have surgery or medicine. They may well be divided into subspecialties such as gastroenterology if it's a gut-based issue, respiratory medicine if it's a lung-based issue. It may be subdivided around the age range of patients. So we have pediatrics, transitional care, teenage young adults, and then we have adult care, and then we have elderly care. We also can be divided into diagnostics or therapeutics. So when we look at radiology, there are certain parts of radiology where they'll just be doing imaging scans to diagnose, but there's also areas in radiology that will actually carry out interventions, particularly in things like neuroendocrine, where we may do embolizations or ablations. Those are interventions, but they're usually done in radiology. So in terms of specialised services, those have been developed, though, to particularly address those with perhaps less common or rare or complex conditions. And the idea of that is to bring together experts who can and experienced practitioners who can then inform what specialist diagnostics and or treatments people with things like rare or less common cancers, genetic disorders or complex pathologies can really sort of make use of and tap into that experience and expertise. And there are about 150 specialised services commissioned by the NHS. I do have to say, however, neuroendocrine cancer is not one of them at the moment. But the value of specialist care is about achieving and trying to reduce variation in care so that just because where you are seen or where you live shouldn't determine the level or quality of care that you can access. It's about setting standards. It's about pioneering new treatments, developing research, but also providing you as individuals with the information you need to make informed choices about your care. It's about, and there's plenty of research that shows that where you've got access to specialist care, whether it be physically being seen at a specialist centre or being able to tap into that speciality for advice about care, we do see better outcomes for patients. And certainly where we look at the next point about expertise and experience, what we've also seen that where we've got practitioners who are focused on a particular field of care, we do see better quality of care delivered. Or so the responses, certainly from patients, seem to show us, as well as outcomes. So, for example, I certainly remember long ago enough, since my nurse training, to see the huge transition for having general surgeons to now having specialised surgeons who specialise in particular surgical techniques. However, this is all brilliant, but there are still issues such as equity and access that I've mentioned around where you live. Do you have that kind of specialist care in your area? Can you get there? More importantly, does the person, the healthcare practitioner you're seeing, know what specialist care is available in your area? And if not in your area, do they know how to refer you outside of area with the necessary support to get there? It's about, you know, healthcare professionals knowing what's in their area, particularly commissioning bodies such as the integrated care bodies and the cancer alliances, because it's important that they are there to serve their population, and that's not just across all common conditions, but also about the rare and less common. If they don't have the facility to provide commission care in their area, there need to be agreed pathways. So, for example, I live in Wales. We have one small centre. It only offers a certain number of treatments. We don't have a gallium scanner here, but we do have a commissioned agreement to access gallium scanners for people who live here in Wales. And so also, this doesn't fully address sort of additional costs sort of to patients, not just physically, as in how tiring it can be or the cost of travelling elsewhere, but it can be difficult if you're particularly symptomatic in trying to make that journey, maintaining your dignity, as well as not exhausting you. And there are particular issues around sort of in terms of healthcare costs. We know they don't always cover or rarely cover those travel costs, but also if there are, if specialist care is too diluted, then those services may not be running cost effectively. So it's how can they optimize access for you who need that expertise as well as deliver it, particularly when you're in an NHS situation where finances certainly are so instrumental in what's available. So why is it important in neuroendocrine cancer? Well, as we said, the whole purpose of specialist care is to provide the expertise and experience to those who may have a particular condition. And in neuroendocrine cancer, we've seen a phenomenal increase in the number of people being diagnosed, but it's not just the incidence. So whilst the incidence has increased phenomenally, we now have about 14 people a day diagnosed with a form of neuroendocrine cancer. It's the prevalence. And access to that specialism means that we are seeing the prevalence. So the number of people living well with this condition is also increasing. And if we look at non-gender specific cancers, then it is the 10th most prevalent cancer in England alone. When you consider there are about 200 or more cancers, that's quite a number when we're considered one of the least common cancers in terms of annual incidence. So incidence is the number of people diagnosed each year, whereas prevalence is, if we look at a particular point in time, is how many people are living with that diagnosis, regardless of when they were diagnosed. So if we looked at today, it would include people diagnosed yesterday, right through to people who may have been diagnosed 20 years ago. So that's why the prevalence can be so large. And in fact, when we do include gender specific cancers such as breast or prostate, it's actually the 13th most prevalent cancer in men and the 14th in women. And so we don't drop that far down despite those huge big groups of people that are included. And to put that into context, when I say about 6,000 people, 14 people a day, that's one person every 90 minutes. But the difficulty here, as you can see, is that we're still, when I first started with the charity, and I've been working with people with neuroendocrine cancer for nearly 30 years now in clinical practice and then with the charity. When I first started with the charity, the average time to diagnosis for somebody with neuroendocrine cancer was 7 years. It has come down in those 9 years to 4.5 years, but that is still a huge way off the target set by the government around early diagnosis. And unfortunately, that does mean that less than a quarter of people with neuroendocrine cancer are diagnosed at stage 1 when it is potentially curable. So there is a huge amount of work and there is importance in being seen by a specialist. And so the difficulty is in that diagnosis. And whilst sometimes symptoms will obviously point to a particular diagnosis, other times many of the symptoms that may be experienced if you do have neuroendocrine can hide or mask the reality of the cause. So misdiagnosis is not uncommon, and it's an issue that goes across many rare and less common diseases, in that you may present with symptoms that may at first glance appear to be things like asthma, IBS, menopause, a number of other things. But there will be an atypical part around that. They may persist despite treatment for that particular diagnosis. And therefore, it's not just about getting early diagnosis, it is about getting accurate diagnosis. And sometimes that does require specific expertise. And sometimes it may only be once you get through to somebody with expertise, and it may be experience. You may be seen by a GP who has also got a number of other people with neuroendocrine cancer. And so their suspicion or for their thinking around suspecting it may be a lot lower than somebody who's never seen somebody with neuroendocrine. So part of what we're trying to address with specialised care is ensuring that not everybody has to be the expert, but they have to have knowledge about it. And it's not just knowledge about the condition, it's what to do if you've got somebody with it. What happens to them? How can we make sure that you get the best care? So it's about ensuring the access to the right healthcare professionals and services at the right time for you to get the best outcome. And as I mentioned, most importantly, it's about giving you the information to make an informed choice about your care. And whilst we may not have an agreed referral pathway or guideline at the present, there are a number of expert guidelines around clinical care. And they all, without exception, recommend that those presenting with a suspicion or confirmed diagnosis of neuroendocrine should be at minimum discussed in a multidisciplinary expert team meeting, and preferably referred to a specialised centre of excellence or a centre of high expertise in the field. So what do we mean by ENET centre or expert centres? And do you actually have to be physically seen at a centre to benefit from that experience and expertise? So the next couple of slides are a wee bit busy, but I hope they'll be informative. So in response to the variability in care that many of those with expertise in neuroendocrine saw across their particular areas, ENETs, which is the European Neuroendocrine Tumour Society, they do know the new terminology is neuroendocrine neoplasms, which covers both NETs, neuroendocrine tumours, and neuroendocrine carcinomas, but they're hanging on to the name for now. But they wanted to set up a way of putting in minimum standards around what constitutes a specialist centre. And the reason for that is that it provides confidence in the people they're treating around the competence and the expertise of the multidisciplinary team. You need to be seeing somebody who understands your diagnosis and has access to the diagnostics and care and treatment that you deserve. It's about the knowledge and adherence to ENETs guidelines, which many of the clinicians in the UK, as well as across Europe, have all put forward to, and looking at what care we're providing, what works, what doesn't, and how people should be treated. That it should be patient-orientated care, and that certainly was discussed much more prominently at ENETs this year, along with, I have to say, a greater adherence to new terminology. And to increase participation in clinical trials. Some of you may be aware of the rare cancer bill that's going through at the moment that had a successful second reading in Parliament last week. And that is around ensuring that those with less common or rare cancers actually have an equal crack of the whip at involvement in clinical trials. And that's from design through to participation and access. The idea was to establish sort of, if you like, a benchmarking tool that allows services who apply for accreditation to be measured against to ensure that the right expertise and experience is present. And I have to say, I had a look through the catalogue that details those standards today. It's 36 pages long and it's pretty intense. And not only do centres have to complete all of those and provide it as evidence of what they have to do an annual return that is not much less than what they have to put forward for accreditation. And so the reason ENETs did this is they do believe that this influence is to lead to a positive impact on your experience of care as well as your outcome from care. So currently, across Europe, there are 68 accredited ENETs centres of excellence. That does include 2 in Australia. They've got in here at ENETs as well as Eurovision. And 14 of those centres are in the UK. Now, per head or per size of country, that's phenomenal. However, rather sadly, I've heard that one of those centres will not be re-accrediting because of a staffing issue with one of the essential disciplines. However, they still have access to that discipline, but just not on site. And so they're holding off re-accrediting, but they still have the rest of the whole team there, and the care should not be altered. But they don't want to fail in accreditation because of that. And so for accreditation, these are just some of the things they have to provide. So obviously being organised, there's no point having a team if nobody knows what they're doing or how they're going. You do need a lead that's able to pull things together and act as if you like, the chair. A coordinator, that's around operational side of things. So making sure the infrastructure's there and required. And then the coordinator usually is the CNS, but in Europe they don't have CNSs in the same way that we do. So it may be a named nurse, or it could be a pathway coordinator, and quality management, of course. Now, they've used some odd terminology here, core partners. That basically means who forms that team. And this is reflected in their MDT. So basically, they need, for a basic neuroendocrine team, you need to have a gastroenterologist, an endocrinologist. We're going to talk a lot of ologists now. A medical oncologist. Now, the difference between medical and clinical is clinical oncologist can also prescribe radiotherapy, whereas a medical oncologist is purely medical oncology treatments. A pathologist, a radiologist, nuclear medicine expert, and a visceral or endocrine surgeon. And that basically means somebody who can operate on the affected organs, be they endocrine or not. If they're also, and this is relatively new, if they're also going to accredit as being a lung neuroendocrine specialist centre, part of that core team needs to include a thoracic surgeon and a respiratory physician. Then we have our additional groups who are not necessarily part of the core team, but there must be access to them to ensure that all options are open. And that means having access to an accredited laboratory service. So when you're measuring things like chromograninase, gut hormones, tumour markers, you don't have to have the lab on site, but you do need to have good access to that facility to ensure that your patients get the right tests for them. You also need to have links with an accredited genetics service. Now, that will become even more prominent in the future, I believe. But at the moment, there are a number of very rare genetic conditions, such as MEN1 or von Hippel-Lindau, that can increase somebody's risk of developing a neuroendocrine. And it can be a gene that can be passed on. So it's really important that diagnosis, we know about that, so that should it be needed, then proper counselling and family screening may also be undertaken. But that's a very small percentage of those with neuroendocrine. I mentioned that might expand, and I think that as research continues and we learn more and more and more about neuroendocrine, that may expand to further testing. Cardiology and cardiothoracic surgery, particularly for those with carcinoid syndrome who may go on to develop carcinoid heart disease. Thoracic surgery, should they be mainly a gut-based NET centre, but you may need to manage either lung secondaries, or you may have people who come to your team who do have a lung primary. Transplant surgery, again, not every centre needs to have it, but they do need to have access into it, as we are now, for a very small cohort of people who fit criteria, are able to offer liver transplantation. Clinical oncology, so access to that. There is a role for radiotherapy for some people with neuroendocrine, particularly maybe lung, but also for those that may have bone mets. It can be particularly effective if you have a solitary bone met that's causing you issues. Also, palliative and symptom control and pain care teams. And for the first time in these new accreditation measures, they've actually included the supportive care aspect and how important it is for the treatment and psychosocial care of people that you do have access to psychological support and nutritional input, such as a qualified dietitian rather than nutritionist. Dietitian is in the UK are the only healthcare professionals that have a legal qualification and responsibility for dietary. Anybody can call themselves a nutritionist, unfortunately, but a nutritionist can be part of a team, but the dietitian is the only one that has that protected role. But also importantly, access to a self-help group or a patient advocacy, patient support group. And again, at ENETs this year, there was an awful lot mentioned about the role that patient advocacy and support groups play in the support and care of people with neuroendocrine. And before I slip to the next page, it's just interesting, I've highlighted it in red here, is that ENETs define a neuroendocrine cancer specialist as any of these disciplines with extensive experience in the diagnosis and treatment of neuroendocrine cancer with a minimum mandatory experience of 5 years. They do have a caveat that if they need to bring somebody in new because somebody is retiring or moving on, that there actually has to be a formal educational and development plan in place to ensure that individual is brought up to speed as soon as possible to be able to provide care. They also acknowledge that actually that because there is no such role as a neuroendocrinologist, what you may see on your letters be signed by, say, a gastroenterologist, but that person has to show this mandatory experience and expertise to actually qualify as a valid member of the team. They also need to be able to prove a defined referral system. So they need to know who's referring to them, whether it's through primary care, A&E, which hospitals in their area or outside of their area are referring to them. And they need to be able to explain and demonstrate how patients actually are referred in, what their criteria is, and how the centres then communicate back with those that are referring in. The MDT needs to be in place, and that often the core rate for that to be considered a specialist MDT, it does need to involve those core team members, plus or minus any of the secondary partners or supportive care. It has to have those core team members present for at least 80% of the time. So they do allow one or two of them to have time off, but they have to provide a certain attendance at there. And that's so that at each discussion, each particular speciality or discipline who may have something to add into care can be there to discuss it, and that it becomes a consensus decision rather than just an individual practitioner that decides on care. The minimum frequency for an MDT is every 4 weeks, and that is mandatory, but they do prefer it's held weekly. And for many of the specialist centres, it certainly is. I don't think any of them can manage to hold off for monthly as it is. And also somebody responsible for quality management. So that means continually auditing, looking at their activity, their outcomes, who's referring, where have they come from, what treatments are they given, what are the outcomes of those treatments, are we achieving all of the aims and objectives and meeting the standards and our own responsibility to our own local population in terms of continuing to provide that service. And that does include things like time targets about communication, our MDT reports done in a timely fashion, clinic letters, things like that, which may cause a wry grin amongst some of you, as well as, like I said, evidence of ongoing training, education, and professional development of those staff. Scientific activity. So, one of the advantages of being in a centre or of excellence, either accredited or able to show high experience, high expertise, is the running of or participation in clinical trials, research projects, both internally and externally, and publications. And evidence of patient involvement. And that's not just around satisfaction of care, it's actually involvement in the information provided, the education. Are they doing that with their patient groups? Are they ensuring patients have informed consent and have access to the support they need? And importantly, are they listening to and responding to patient feedback? And if you have an hour or so to spare and would like to see all the other criteria and the depth of information, there's a link there. And this recording will go on to YouTube once we've sorted things out. And I'm more than happy for the slides to be shared as a PDF. However, some of you may know that not every team that could be accredited is. And accreditation is not awarded. You do have to apply, and it's not cheap or without cost. And it's the team's decision on whether they apply for accreditation or not. An accredited centre does not get any extra financial support from government or the NHS. It's purely a recognition of the expertise and experience they have. So whilst your team may not be a centre, they may still have the core team members alongside the secondary and support partners that accreditation would require. They may still hold regular MDTs and clinics and provide the expertise and treatments that the standards for a C of E requires. And each works slightly differently. So some local teams will work collaboratively with a specialist centre or team, and some centres will work in a hub and spoke. And for example, I worked at King's, and did we see everybody? No, but we had some neuroendocrine champions in our referral area. And unless somebody had to be physically seen at the centre, then we would work with within that hub and spoke model to ensure people had timely access to diagnostics and treatments. And only if those things weren't available locally would somebody need to come up to the centre. So it can help reduce the burden of travel while maintaining that expert input. And this I stole from ENETs. It doesn't show all of the centres or specialist MDTs that do have that high expertise, but it certainly shows, there are obviously some gaps that we can see quite clearly around the country. And it's about filling those in or ensuring people in those areas still have access to the care they need. So in terms of the teams themselves, MDTs, some of you, so for example, I said I was at King's, but a lot of the oncology was given at Guy's and Thomas's. And so sometimes it wasn't practical. It could take as long to get from Guy's and Thomas's to King's as it could to get from London to Oxford. And so sometimes they would join in virtually using the technologies to bring everybody together. But it was still important that everybody at that meeting, whether virtually or in person, was corate. So we did need to ensure we did have all of the core team members present. And so, for example, for certain MDTs like the transplant in neuroendocrine cancer, that's a national MDT. And so that is virtually. And some teams use technology such as telemedicine to link in with patients so that they can access the services remotely, especially where travel to a centre or a team may be difficult. And again, talking from my own experience, this bearing in mind this is 10 or 12 years ago, we'd already run a successful pilot in liver disease. And one of my CNSs was a lead on primary liver cancer, and she had a very successful liver cancer telemedicine, because the beauty of telemedicine is you can actually see each other and you can pick up those non-verbal cues and have that discussion, provided both sides of that telemedicine consultation were invested and involved in that discussion. And so it can work, but you do have to be quite careful and in selecting who that best suits. So how can you find out whether your hospital or your team has that high level of non-experience and expertise? Well, first off, you can ask them, what is their own experience? If you're talking to someone and they say, oh, well, you're quite interesting, don't really know much about this, then you can obviously say, well, are you going to be talking to a specialist centre or refer me on? You know, do they, ask about their appearance? Do they have a specialist neuroendocrine MDT on site or access to it? Do they regularly link in with a specialist centre if not on site? ENETs, there's a web link there, although you do have to scroll past the bite-sized guidance to find it, but you'll see the map, but under the map is a listing of all of the specialist centres, but also the recognised MDTs around the country. Not 100% up to date, but it does give you an idea. You can ask us. We have some information on those, and we have a list of the clinics and centres that are there. But also your Cancer Alliance or Integrated Care Board team should know what specialism is in your area. They're responsible for the commissioning and provision of healthcare. And so even though there is no specialised commissioning currently in place for neuroendocrine cancer, they should be aware of what services they have in their hospitals and clinics and be able to signpost to those areas. The hospital website, does it mention neuroendocrine? Is there anything on there about it? Do bear in mind that the corporate communications teams in many hospitals don't necessarily, there's some variation in whether they keep that page up to date or not. But the internet, you can check out your hospital or your consultants. You can find out in their bios, do they list experience, expertise? Have they published? Have they undertaken research? These are all different ways that you can find out. And what we hope to do with some of the work we're doing is actually to move towards having this recognised pathway for services for people with neuroendocrine cancer. And so what are referral pathways? I've just told you we don't have them or the commissioning centre, but what are they? So a cancer pathway is meant to be a way of easing the referral from the presentation of symptoms onto diagnostics, accurate diagnostics, and the right treatment, and then to follow on care. Care doesn't finish at the point of treatment. It should continue. And for many people with neuroendocrine cancer, that will be lifelong. And so we do need to get you to the right place at the right time. But the care pathways also provide a guide to healthcare providers, be they primary care or local DGHs, to deliver the standardised and optimal care to patients. So in other words, they know if they don't have the service there, who they need to be referring on to. And according to the UK strategy for rare disease, it's absolutely essential to have clear, accessible, effective pathways, although we don't yet have one for neuroendocrine cancers. However, NHS Wales does have a single care pathway for neuroendocrine cancer. And although you may not see the detail over here, this top line is about how people may present, whether it's through primary care, A&E, diagnostics for something else, or urgent referral, and then what happens. And this describes sort of some of the local tests they may have, a local discussion before referral on to specialist care, who will then decide on care, whether they confirm a diagnosis or not, and then set out a plan of care. For most cancer types, there are guidelines for GPs. So if you look on the NICE website, there's something called NG12 guidance, and that lists a whole host of various symptoms and signs, and then suggests what the primary problem may be. And there are urgent cancer referrals for certain cancers. However, you may not be surprised to hear that neuroendocrine is not currently there. And having trawled through all of it, I can tell you they're not there, not even as a differential. And in fact, it's only been recently that IBS over 50 or similar symptoms has been linked to potentially being a symptom of ovarian or gynecological disease, despite the fact that we've known that for a very long time. And so what does this referral pathway look like? So essentially, this is sort of, if you like, in the more common cancer journey pathway. So you don't feel right, you go to your doctor, and if they suspect cancer, or even if they're uncertain, but they don't think it's enough to sort of just mess about with, they will then refer you on. And so, as I mentioned, there are referral pathways for many of the cancers. So if you've got gut issues, they will refer you on as an urgent referral to a gastroenterologist. If, however, you've got symptoms, but they seem to be non-specific, but your GP is still not happy that things aren't right, there is a non-specific pathway. And they are now being, people with those kind of symptoms are being referred on to something called a rapid diagnostic centre, which can undertake a full history and look and do diagnostics to then inform ongoing care. And we're still, they're relatively new, but we are starting to see results coming from that. They are picking up cancers, probably at about the same rate that 2-week wait referrals are, which isn't as high as you may suspect. I think it's less than 10%. However, so a traditional or a more common cancer pathway would be you present with symptoms, you're referred on to diagnostics, a diagnostic is made, and decisions around treatment happen. And then you have various treatment cycles, and then either are cured, go into remission, or progress. But it's about the timeline. So from referral to the first treatment is 62 days. This is what's currently happening in neuroendocrine. So supposedly a similar pathway. However, this first stage from symptoms to diagnosis, as I mentioned, it is around, sort of our latest figures show it's around 4 years. Obviously, that is more common in the majority of neuroendocrine cancer patients who have a neuroendocrine tumour. But by that time, people may have had 11 GP visits, etc., have bounced back and forth. So this is what we need to address in terms of improving things. So how do we get you being referred? So under the NHS Constitution, you are entitled to ask for a referral for specialist treatment on the NHS. Whether you'll get that referral can, in some cases, depend on whether your GP feels it's clinically necessary. However, you do have that right. The exception to that is if you're being referred as an urgent referral, wherein you may not be offered initial choice because expediency, getting you seen as soon as possible, takes priority. And once you're diagnosed, then there is a choice of where you go on to have care. However, very few people with neuroendocrine actually end up being referred through what used to be called the 2-week wait. Many will either be caught through screening, or through being investigated for something else, or through presentation in A&E. And so The legal right to choose may be limited if you do go through the urgent pathway. However, if it's very clear that you may have neuroendocrine, then direct referral to a specialist centre is encouraged. You can choose if it's likely to be longer than a 2-week maximum wait time, and once you are diagnosed, you do have the right to choose. That's best practice and is essential. So I'm going to just finish off with some of the work we've been doing. So some of you may know that 18 months ago, 2 years ago now, we did launch what we consider to be our ideal pathway. And it does address it. We're not asking for anything extra. What we are asking is to be included in some of the mechanisms that are already set up, to have neuroendocrine included as a differential so that people at least suspect it, and to have the right to be able to access the right diagnostics, the right specialist teams. The teams are already in place, so the NHS doesn't even have to invest in building them up, though it may help if they put a bit more investment there, particularly with some of the staffing issues that are going on at the moment. But it's also important, I think, for the healthcare professionals involved to know where to turn to for advice and information and where to refer you to. And currently that's not there. Though the document has been endorsed by a number of specialist organisations, some neuroendocrine specific, some wider, like the Cancer 52 and Maggie's. And our next steps are about spreading awareness of this, adapting the pathway to different regions where we may see some geographical differences in the types of neuroendocrine cancer, and also piloting it within an alliance. I was at a meeting last week with the Somerset, Wiltshire, Avon and Gloucestershire Cancer Alliance, and we're hoping that we've been in discussions with them about the possibility of piloting it there. And there may be another cancer alliance that has shown interest. And again, if you want further information about this, it is available on the website. And I have no doubt we'll be asking for your help in spreading awareness and pushing this forward. But it's may take a little bit of time, because with a change in government and with the announcement last month of the new cancer plan, so having got rid of having a national cancer plan and replacing it with the major conditions strategy, we've now about faced, because of demand, but also because of Lord Darcy's report on the NHS that was published last year, the government have decided to reintroduce a national cancer plan for England. The devolved nations already each have one. What was interesting about this announcement is it's the first time that it has been clearly stated that the National Cancer Plan will also seek to improve the outcomes for those diagnosed with rarer and lesser common cancers. If you've seen any of the other previous national plans, you'd be lucky to find more than a couple of sentences about you guys. And you form part of almost half of all cancer diagnoses. And so what we've done is there is some further information about the currently open consultation on the National Cancer Plan on our website in the news section, and there is an opportunity for you to have your say and put forward your views in this. The open consultation doesn't close until midnight on the 29th of April, so you've got at least a month. It does at first view look a wee bit like ticking boxes, but each question also has a text box. If you don't feel that the questions or the tick boxes fully reflect what you want to say, there is space for each question to add in your recommendations. I'm also slightly hopeful that the attention may be seen because of the successful passing of the into the next stage for the Rare Cancer Bill, which also focuses on the concentration of investment in research and trials and pushing knowledge forward in rare and less common cancers.